being here. Really looking forward to this session. As described, I'm with DevX, and DevX, we're the media platform looking at global development and health. And I just want to say we're so happy to be partnering with the commission around this event. I've been here for parts of it, much of it, and it's been just such a fascinating series of topics on such important issues. So thank you for being here, and I'm looking forward to this conversation with KP Yelpaala. I'll bring you up here. I've known KP for, sorry, I'll give you this. Oh, okay. I'll take this. All right. So KP and I have known each other for about 20 years. Close.
Yeah, close.
And he's really he was the innovator in health before innovation was cool, I would say. And has done a lot of different things over the years. Currently at the Yale, leading there as a lecturer and also leading the Innovate Health program, but has also started a couple of businesses in this area. One called Access Mobile, one called In On Health. And it's been fascinating to me because both of these businesses have been in different settings. Access Mobile was very much focused around digital health in Africa, and In On Health was very focused on digital health in the United States. So you've looked at both of these segments. Can you talk a little bit about what you've learned through that experience and what the differences are between those two? As we all know, I'm sure there's many differences. So a bit about what those differences are.
Yeah, thank you so much for having me, and it's nice to be having this conversation. We've known each other a while. This has been a point of reflection as I've gone back to Yale. It's my alma mater. I trained there many years ago, and I'm actually teaching a class on health innovation as we speak. And so a lot of my reflections have been, what have I learned? So just for background, the company I started, Access Mobile International, was one of the first investor-backed digital health companies in East Africa. I was very early. I started that company in 2011, and that was a time when everyone's thinking about the role of mobile technology and cloud infrastructure, kind of creating a leapfrog opportunity for the African health setting. And so the thought was, Microsoft was one of our main investors. We were one of their first 5 Africa Innovation Award winners. And the thought was, could we kind of support digital transformation? So all the foundational things that you need, even now when we talk about AI, cloud infrastructure, kind of moving people from paper to electronic, integration with telecoms to facilitate texting and then telehealth. I think what I learned is, in the African setting, the mindset was very tech forward. And I think what we learn is that the models that have persisted are more what we call tech-enabled service models. So there's so many different barriers and challenges and friction around healthcare in the African setting. And a widget, if I can say it that way, alone isn't enough. Like, you really have to think about the holistic problem you're solving and what the role of technology is in solving that problem, and then what the other things are wrapped around that. And I think it wasn't just me. I think there was a lot of tech enthusiasm at that moment, and I would say that was the biggest lesson I learned. Funny enough, it's a similar lesson here in the US. So particularly with COVID, in 2021, the US had $30 billion invested in digital health. And that was more than double than the year before. And it was more than double than the year after. We know in 2022, investment dropped dramatically for a number of reasons. But I think the big lesson for investors that rushed in the US market into digital health was that, again, technology alone doesn't solve these challenges that we're trying to deal with. And I think the same lesson I learned in Africa we see here is that the companies that have persisted are truly tech-enabled service models that are built around solving a very specific patient population need or a very specific population health need. They've understood the economics of that, how the pain points look for different stakeholders, and then they wrap tech around the solution, but it's not the driver.
Mm-hmm. And back when you started these businesses, especially with the focus on Africa, The talk in sort of global development, global health circles was very much about donors, right?
Right.
About like money coming from the U.S. or OECD or wherever it might be. And yeah, that ship has sailed in many ways.
Right.
And you were already talking about local ownership a long time ago.
Right.
And how important is that in the whole process?
It still is very important. And I mean, one of the things I still think about a lot is the role of the private sector. So when I started the company in the African setting, my background would have, one would have assumed I would have started an open source nonprofit organization. But my values were to say, for sustainability, could I sell a product to the private sector? So my clients, we actually took a city-based strategy. So it wasn't like we just worked in Kenya, we worked in Nairobi. It wasn't that we worked in Cameroon, we worked in Douala. And in those cities, we saw a booming middle class that was looking for more access to quality healthcare service delivery. So the private hospitals that were serving that growing middle class, we were thinking, how can we make them do their job better through tech? And that was my customer. So I was selling what we call a B2B SaaS, software as a service model, to African hospitals, right? And, having been someone that worked in the donor side, I always ask myself, we've pushed billions of dollars into the public health sector. But if you ask the average African where they'd prefer to get their services, most of them wouldn't choose to go to a public sector hospital for care. If they had the money, they'd go to a private sector facility. And this is kind of the elephant in the room. So I think that I'm not saying the private sector there's still a lot of access challenges, but it has a role to play in this health ecosystem. And when we think about tech innovation, we have the donors on one hand, primarily working through the governments, and then we have the private sector trying to fulfill the void. But if there's not a lot of health insurance and people can't afford, it's not solving the whole problem, but it's part of the solution as well.
Great, and let's shift gears a little bit about your current work. You are the faculty director of Innovate Health at Yale, and we're seeing so many sort of technology shifts in healthcare. I mean, in society at large, but healthcare included, AI, automation, these sorts of things. What are you doing? What is Innovate Health at Yale? What are you doing to help navigate, but also bring in these tools?
Right. So my role at Yale kind of has two layers. So on the one hand, at the Yale School of Public Health, Innovate Health Yale was the first kind of social entrepreneurship program for public health in a school of public health. So it's been around since 2013. And so we fund student innovators, and our innovators have started companies, nonprofits, many of them have actually scaled in different contexts. So we're proud of that legacy. But if my dean who brought me on to think about this more broadly said, look, there's two things we need to achieve. One, for faculty, and I think this is an issue in academia, faculty at Yale that have innovative solutions that can support population health need to think about how to get their research and work out of academia and into the world. So what is the way that we take the important evidence-based work that Yale faculty are doing and have it not just sit in the ivory tower and get it out in the world? So my role is to work with our faculty that are doing really innovative things to think about partnerships with public sector, private sector, how to move their innovations out in the world. At Yale, generally speaking, I also lead non-life sciences health innovation. So if you look at academia, a lot of the innovation coming out of academia is in the biotech and life sciences space. But the feeling in institutions like Yale is that there's a lot of innovation that's not life sciences, but that can benefit the world. Now, we understand that universities benefit from the intellectual property of these solutions, right? Because if Professor X develops a molecule that's acquired by Pfizer, that's a windfall for the university and the professor. But what about other innovations? So we're thinking pretty hard at Yale about population-level health innovation and how we partner and create channels to get that work out in the world.
And you mentioned a lot of the work the faculty are doing, but I imagine the students are very much involved as well?
Of course, yeah. So the student work continues, but we've, as far as my dean's concerned, that's one strand of work, but then we need to do another strand of work with our faculty. So that's the next kind of vision that I'm working on. And we're launching something called the Future of Health Innovation Hub. It'll be announced officially soon, but the idea is to kind of take these ideas I'm talking about with faculty, students, and international partners and kind of have a co-creation innovation space where we can really get these ideas out of the ivory tower and into the world.
Mm-hmm. A lot of the sessions I've been at here at this event have been around accreditation and the importance of it and effective accreditation, essentially. I know we've spoken about how these accreditation boards how it's so important,
right,
but they sometimes have some challenges dealing with some of these big sort of transformative innovations, things like AI and new technologies. What do you think the future looks like for those, and what do you think the state of play is?
Yeah, I mean, I think there's two things. So I think first I'll talk more broadly, then I'll talk about public health. But I think we're all experiencing this with technology and specifically with generative AI. There's so much that these tools can do to help an individual around supporting health needs in their community. And when we think about the labor shortages or the skilled healthcare worker shortages, at some point, I think we're pushed to think more broadly about what the base level skill set is for someone to do certain activities. So as an example, and I'll just give an example, in Africa West, so West Africa, in the World Health Organization's projections, there's a 1.4 million person skilled healthcare worker gap today. So we have 1.4 million health workers that we need today we don't have. Clearly, training people in traditional ways is very linear. We'll be doing that for decades and the gap will just be increasing. So the question is, how do you fill that gap? There is a training element. We do need skilled workers. We need specialist physicians. We need telehealth. We need all those things. But at the base of the healthcare pyramid is primary care. And a lot of primary care needs, if you get the right person with the right tools, a nurse practitioner, a physician assistant, a community health worker, they can do a lot. Mm-hmm. And I think it's a challenge for traditional accreditation institutions to make that shift. Part two is in public health. Public health learned the lesson the hard way because we were caught flat-footed during COVID. And really, I think what actually happened with public health is that the field wasn't ready to respond to that type of pandemic based on the skill sets that were, in terms of how people were being trained. So let's just talk about public health communications. If you take a traditional public health communications course, no one's talking about social media, no one's talking about mis and disinformation. None of that was happening. Yet then our public health workers found themselves in a scenario where they were supposed to know how to talk to the media. They're supposed to know how to look at social media data sets and all these things, right? And so I think public health as an accreditation committee is actually existential now. They need to think very quickly, in my view, about what public health, let's call it maybe 2 or 3.0 looks like from a training perspective. So my course train students in these novel ways. So my course has become the biggest elective at Yale because I'm a practitioner and I'm coming at students with these very real world challenges. But it's a more existential issue for the field in my view.
Yeah, and you have, there's two things that are certainly happening. One is a lack of health workers. Yeah. Another is revolutions in technology. Yeah. So the key is how to solve one with the other, right. Especially in some of these less resourced areas that don't have access to the same technologies.
100%. Yeah, and I think that the principle is do no harm. So I think like anything, we're thinking a lot about ethical and safe uses of AI, right? And I think it's up to each, we can set standards and guidelines with the global bodies, but then it's really up to each jurisdiction, each country, to decide what that right balance of risk and reward is. Because again, if you have a 1.4 million person skilled healthcare worker gap, you have to do something, right? There might be perceived risks in terms of safety, which we have to consider, and ethical concerns, and there's also more access. I think that's the policy dilemma, and I think different countries, I think progressive countries from a leadership perspective will be rewarded. That's my own personal opinion. and kind of leaning in thoughtfully.
Other than the words AI, do you see AI actually make its way in? People talk about AI all the time, but then well, what does that actually mean? It's like, well, I use ChatGPT. And is it like the actual usage of it? Do you see it coming into the medical profession?
I'm looking at it a lot actually now, and there's a lot of interesting work around large language models, so the engine behind chatbots in the medical space. But I'll give you one example of something that I look at specifically these days. The issue is language. So right now with large language models, they're primarily in majority languages. So if you speak an edge language that's not in the models don't work as well. So Gates Foundation funded a study. It came out in December of 2024, and what they did is they looked at medical large language models. So these are large language models trained on medical data. And so they set a baseline. So in English, you could ask this large language model many medical questions. Its score was about 95% on average, accuracy. Then what they did, which was really interesting, is they took dominant African languages, like 7 different African languages, and then they asked the large language model the same questions, but in those African languages. On average, the responses were 30% less accurate. So the average score was running more in the 60s. So the challenge is if an African innovator builds a chatbot in Yoruba for diabetes right now on that, the ethical dilemma is we know today that it's not going to work as accurately as English. So these are some of the practical gaps. And I know Nigeria just had an announcement this week about some work on large language models in Nigeria in different languages, but that's kind of where the rubber meets the road is language and kind of training these models into edge populations. Because right now it's English, Chinese, Spanish, Hindi. These
Probably
are some of the
French.
languages, huh?
Probably French, isn't it?
French. These are like some of the languages that there's larger data sets. But at the end of the day, I mean, 80% of the data that large language models are trained on today is in English. And 20% of the world are first primary language English speakers.
Well, thank you. I've really enjoyed this. This buzzed by. We'll get the hook here if we don't get off stage. But thank you so much, KP. Really appreciate it. And please join me in thanking KP for this session.